Hola, buenas noches a todos y todas, los presentes en el Zoom y los presentes en el YouTube Live. Hoy día voy a hacer una presentación breve ahora en español, porque vamos a presentar al profesor que tenemos invitado, que es el profesor Christoph Lees, quien nos da el honor de estar hoy día presentes en este último webinar del año 2021. Pero también voy a hacer una breve presentación ahora en inglés, para que Christoph también pueda entender algo de la presentación. Esta va a ser un webinar en inglés. Espero que sea de vuestro agrado, porque realmente Christoph es un gran profesor británico y es un gran presentador también de esta temática, que es muy interesante. Así que les voy a hacer una breve introducción a Christoph para que partamos este webinar y ahí dejarlo a él con la palabra. So good night, everyone, everybody that sort of listen us in different platforms. In this 16th version of the webinars of our fetal medicine unit, we have a great international guest tonight. Our guest today is Professor Christoph Lees, along with being a great British professor and researcher at Imperial College in London and Queen Charles Hospital. He's also a great friend with whom we shared good moments at Professor Nicolaides King's College between 1997 to the year 2000. Christoph has published more than 200 articles in the international journals, having more than 11,000 citations. He has directed several research projects, the best known being those related with uterine artery Doppler as a screening test for preeclampsia and fetal growth restrictions, the TRAFL project, which changed the management of fetal growth restriction, and recently, the use of high-frequency ultrasound as a TTTS therapy. So tonight, the talk by Christoph Lees will be on the role of maternal hemodynamic in the management of preeclampsia and fetal growth restriction. Christoph, please, it's your turn.
Wonderful. Thank you very much indeed, Mauro. It is a great pleasure to speak to you this evening. And yes, indeed, we worked together very closely for 3 years, 2 decades ago. And some of the work I'm going to reference tonight actually goes back to that period of very intense research at King's College Hospital with Harris Birthright. So anyway, Mauro has asked me to talk to you tonight about the obstetric management and maternal hemodynamics and its implications. So I'm going to go over what we understand now, what we've understood from the last several decades, and what that means in the context of our latest research over the last 5 or 10 years. And a lot has changed, so I'm just going to explain some of that to you now. So let's just look at some very old papers, and I think many of you will know probably the papers of D.J.P. Barker, very classic papers from the 1970s, 1980s. And D.J.P. Barker looked at the developmental origins of disease. And in this classic paper, and this lecture was back in 1980, I've forgotten exactly when, but 1980 something, showed that from a cohort of men and women born before the Second World War in Hertfordshire, a county in England just north of London, that the smaller the babies were, the higher the risk of cardiovascular dysfunction and mortality later in life. So there's a higher risk of diabetes, high risk of cardiovascular disease, high risk of stroke, high risk of death. And that was particularly marked for men. It was also for women, but it was particularly marked for men, as you can see. So as you became smaller, your risks went up. There was a bit of a problem with this data because what it looked at was just birth weight. And birth weight is a very crude proxy of fetal growth restriction because, of course, it depends on when a baby is born. So in this next piece of work from Barker and his group, they looked at not only birth weight, but birth weight in relation to the placenta. The theory being a small baby with a big placenta was much more likely to be growth restricted. And when they looked at this, they found that the babies indeed with the biggest placentas in relation to the smallest birth weights had the highest blood pressure later in life. And length of gestation had no effect. So by doing this study, they were able to tease out the effect of gestational age on birth weight. And this is very nicely written. It's definitely worth reading, this paper from the BMJ from 1990, because, and I'll just quote, these findings show for the first time that intrauterine environment has an important effect on blood pressure and hypertension in adults. The highest blood pressures occurred in men and women who had been small babies with large placentas. So this is telling us it's not just being small, it's being fetal, it's having fetal growth restriction that was particularly the risk factor for hypertension later in life. So this and other studies have tended to point to the placenta as the problem. So because of this placental birth weight ratio, because the placenta is what we can see that is the interface between the mother and the fetus, there has over the last 5, 6, 7 decades been a relentless search on to understand what it is about the placenta that causes the problems for the baby and causes the problems later on in life as well in relation to cardiovascular function. But I'm going to put it to you, and some of you will have heard other talks of this type, though I diverge from, for instance, Baski and some others on some key points. But is it actually the placenta? And to start understanding this, we need to go back to some classic papers. Now, this paper is from American Journal in 2019, but it's a sort of republication of a paper that was written back in the 1960s, placental bed research, from spiral artery remodeling to the great obstetric syndrome. So this paper was only written 2 years ago, but is based on a paper from the 1960s. And this is one of the very nice diagrams from the 1960s showing the arcuate artery, the radial artery, and you can see at the bottom there the spiral arteries. And the concept that a spiral artery that hadn't undergone modification was led to a much higher risk of preeclampsia and growth restriction, and was therefore much more associated with maternal cardiovascular dysfunction. And that is from Brosen's classic PhD thesis from 1965. So that is a long time ago. That is 55 years ago, 57 years ago, I'm sorry. And this is further work from Brosen's looking at the spiral artery remodeling. And you will have all learned this, I think, at medical school, spiral artery remodeling, and the fact that spiral artery remodeling does not happen properly in babies, or rather women who have preeclampsia and women who have growth restriction. And you will have seen a lot of histology images like this showing a uteroplacental artery at the top with physiological changes becoming much wider and dilated, allowing good blood flow through it. This is panel A, and panel B below. Can you see that thick muscle of the spiral artery in the junctional zone, which is associated with preeclampsia because of an absence of physiological changes? Really lovely paper this. I would recommend you look at this, 2019 American Journal. Well, now we come on to clinical obstetrics. So this is what the placenta says, this is what the placental histology says, but how does it fit with actually what happens in fetal medicine and what happens in obstetrics? And this is where Mauro and I spent 3 happy years together doing a lot of Doppler in women at very high risk of preeclampsia, because in South London, where we were, there was a very high risk of preeclampsia. And also there was a real custom, a tradition for women coming and undertaking the research with us, so letting us do lots and lots of scans. So it was a perfect place to do a lot of research on uterine artery Doppler and on preeclampsia. And you can see here in this diagram that at 8 weeks, at the level of the spiral artery is very thin and very tortuous, and it becomes dilated by 16 weeks. And at the same time, The blood flow, let's look at the uterine artery right at the bottom here. The uterine artery goes from high resistance to low resistance waveform. So that was in our minds, that was what was happening. The spiral arteries were opening up, they were becoming larger, the blood flow was greater, the resistance was going down. And this was particularly so in the context of women who had normal pregnancies. But if there was poor spiral artery adaptation, the resistance remained high. And that was what we saw with uterine artery Doppler and the Nicolaides program in the first trimester, looking at uterine artery Doppler and the association between high risk of preeclampsia and growth restriction and high uterine artery resistance, and the work that Maura and I did at 20, 22, 23 weeks, showing that high resistance equals high risk of preeclampsia. And this work started in the 1980s, late 1980s with Kevin Harrington and others, and it showed that indeed high resistance uterine artery blood flow, bilateral uterine artery notches led to a much, much higher risk of preeclampsia and related conditions of pregnancy. Interestingly, smoking prior to pregnancy slightly reduced that risk. We don't know why, but it's a consistent finding in all the studies that smoking prior to pregnancy slightly reduces the risk of preeclampsia. First pregnancy obviously increases the risk, and this is a uterine artery waveform with a notch and with high resistance. So I think you're going to tell me, well, we know all this. Why is he telling us this? Well, I'm just going to stop for a moment and show the pioneers, the absolute pioneers of this work, Kypros, Nicolaides, and before him, Stuart Campbell. I'm still in touch very much with Kypros and also with Stuart Campbell, and I worked for both of them, and they both had slightly different views of uterine artery Doppler, but both thought it was very important. Now, you would have thought if uterine artery Doppler gave a high resistance waveform, and that was associated with preeclampsia and fetal growth restriction, that in these placentas of women with very abnormal Doppler, you would see something. And indeed, if you look at lots of papers, including Brosen's papers, preeclampsia and growth restriction, they all tell you about thrombus, about infarct, about inflammation of the villi. So we wanted to investigate this. So with Sangeeta Pathak, who was a fellow of mine about 15 years ago, we looked at over 1,000 women who delivered consecutively in Cambridge. So we got their consent to look at the placenta, and we sent these placentas completely blind to pathologists. So the placentas appeared with a pathologist. The pathologist did a standardized examination of the placenta and did not know if a woman had preeclampsia, growth restriction, diabetes, whatever. They didn't know that. And we did standardized measurements, standardized blinded histological examination. And what did we find? Well, we found that preeclampsia occurred in about 2% of women, pregnancy-induced hypertension 3%, SGA 6%. So that's what you'd expect. And we published a lot of papers on that. And importantly, we showed absolutely no difference in the histological findings of women who had no preeclampsia, no growth restriction, or those that had preeclampsia, those that had growth restriction, or those that had both. There were no differences. No histological differences. So that was a bit of a shock. So if we look at where we are now with the placenta, is there actually an association between abnormal spiral artery adaptation, preeclampsia, and growth restriction? And apart from Brosen's work, there really isn't much strong evidence for that. There probably is for really severe early onset preeclampsia, but for preeclampsia generally, probably not. Abnormal placental morphology in preeclampsia and growth restriction, probably very little evidence, and I would say no evidence for that. One thing is true, and that is placental biomarkers are abnormal in preeclampsia and growth restriction. But of course, placental biomarkers don't just come from the placenta, they come from also the vascular endothelium. So what we call placental biomarkers aren't necessarily placenta. So I think that there are enough question marks about the placenta's role in preeclampsia and growth restriction for us to look elsewhere and look at other explanations for these terrible conditions that can cause death of baby and death of mother. And over the last decade, there's been a lot written on maternal cardiovascular function, either prior to pregnancy or after pregnancy or during pregnancy, and looking at whether we can predict preeclampsia and growth restriction based on abnormal cardiovascular function, or whether abnormal cardiovascular function in pregnancy leads to abnormal cardiovascular function after pregnancy. And it's a bit complicated, and I'm going to try and simplify it for you. So I'm going to show my very good friend Herbert Valenzi's work. Herbert works in Rome, Tor Vergata, University of Rome, and in hypertension in 2008. He was the first person to come across this concept of early and late preeclampsia. Now, early preeclampsia, interestingly, is very strongly associated with growth restriction. Late preeclampsia is often associated with big babies, but the key differentiator is whether there's growth restriction or not. Now look at this diagram here, and it takes a little bit of thinking about. Blood pressure is on the vertical axis. Cardiac output, maternal cardiac output, is on the horizontal axis. And along here are the lines, sort of radial lines, and they give you TVR, which is total vascular resistance. And can you see this little group here on the left have high blood pressure, they have low cardiac output, very low cardiac output, these mothers, 2.53 liters per minute, and they have spectacularly high vascular resistance. So that is the early preeclampsia, and what I'm telling you is that most of those early preeclampsia cases are associated with growth restriction. Now let's look at the late preeclampsia. Now the late preeclampsia, a completely different group. They're at the other end of this graph. And they've got a very large cardiac output, some cases 8, 9, 10 liters a minute, which is an enormous cardiac output. And the vascular resistance is, interestingly, quite low. So you can see immediately that there are two different phenotypes of preeclampsia here. Sorry, early preeclampsia with fetal growth restriction and late preeclampsia without growth restriction. And the two are opposites. In one group, you have a low cardiac output and very high vascular resistance, the group with fetal growth restriction. In the late group, or the group without fetal growth restriction, you have exactly the opposite, high cardiac output and low vascular resistance. But we treat these conditions as if they're exactly the same. We give the same medications to women, irrespective of the type of preeclampsia this is. Now let's fast forward to 2012, and Karen Melchiori, working with Baski at St. George's, showed a similar sort of thing, that that the women with these are controls, and these are women with preeclampsia and fetal growth restriction, and you can see that they had very high vascular resistance and very low cardiac index. So again, different group, different patients showing exactly the same thing. And if I show this schematically, what I think probably happens with these women, they start with potentially healthy blood vessels, normal cardiac output, heart pumping away. But some, in their pregnancies, for whatever reason, develop an abnormal cardiac output, and the heart pumps with less contractility, probably pumps slower as well. There's a relative bradycardia, interestingly. And whether it is the poor pumping of the fetal heart or something else, that to maintain blood pressure, you've got to constrict your vessels. So the vessels constrict and the blood pressure goes up, and that puts more of a strain on the heart and leads to even lower cardiac output. So you can end up having a situation with a negative spiral, even more tightly constricted blood vessels, leading to a lower cardiac output associated with poorer uteroplacental perfusion and higher blood pressure. So let's look at what one of my fellows, now a consultant colleague, Jasmine Tay, worked on roughly 3-4 years ago. So we said, okay, let's forget about early and late. Let's just recruit all women who come in with preeclampsia and fetal growth restriction to our unit from after 24 weeks. And we will normalize all the cardiovascular tests for the gestational age. So I don't care if it's early or late, because we'll adjust every cardiovascular measurement for that gestational age range. So what do we find? Well, we found that the moment you do that, the moment you take gestational age out of the equation, cardiac output is lower in women with growth restriction, and is even lower in women with preeclampsia and growth restriction than controls. And interestingly, it's exactly the other way around for vascular resistance. And let's look back at this graph here. In preeclampsia, without fetal growth restriction, the cardiac output was high and the vascular resistance was low. We give women a term with preeclampsia, we give them vasodilators. Why do we give them vasodilators? They already are vasodilated. They've just got a very high cardiac output if they've got normally grown babies. So look at the differences there. And what I want you to take, the take-home thought here is FGR and preeclampsia with FGR are opposite to preeclampsia. So let's go to Herbert Valencese's wonderful analogy here. And the problem here with the radiator is either because the pipes are choked up, they're calcified, there's nothing going through them, or it's because the pump, the boiler itself doesn't work. So remember this, there are two things that cause poor oxygenation, poor nutrition to the fetus. One is a really bad placenta. The other is really bad blood supply to the placenta. So I think I've shown you that maternal cardiovascular function is abnormal in established preeclampsia and growth restriction. But then the question is, what happens in early pregnancy? Is cardiovascular function before pregnancy or in early pregnancy associated with growth restriction or preeclampsia? Now, we all see these pictures all the time in textbooks, and I just want to show you this picture because just look at what happens in this very early phase, the first trimester. No one does measurements until 12 or 13 weeks. So everyone sort of forgets and ignores the first trimester, and they draw lines going from 0 to the second trimester. But actually that's a real problem because a lot happens in the very early first trimester and we tend to forget it. This paper from Kidney International 20 years ago, Chapman et al., following up women who were healthy here, but in very, very early pregnancy. And what did Chapman find? Well, Chapman found that the mean arterial pressure, and this was about 6 or 7 weeks, dropped by 6 or 7 weeks. Cardiac output went up hugely by 6 or 7 weeks, and vascular resistance fell. So there were profound changes happening within 2 weeks of conception. Preconception studies are very difficult to do, though. But one person who did it was another fellow working with me, Amita Mahendru. So she did what was called the IMPOST study in Cambridge in about 2010, 2011. And we found that cardiovascular function was very different at the time of prior to pregnancy compared to early pregnancy. And this was about 6 weeks. So augmentation index, which is a measure of arterial function, augmentation index dropped from pre-pregnancy to early pregnancy to 6 weeks, very, very profoundly. And then there was only a relatively small further drop to the second trimester. So what I'm trying to say to you is that actually a lot of these changes have happened by the time 6, 7, 8 weeks have come along. And certainly by 10 weeks. So just taking that a few steps further, profound cardiovascular changes occur in a very early pregnancy. Preeclampsia and with fetal growth restriction and fetal growth restriction are associated with low cardiac output. So you can imagine the placenta isn't properly perfused, and high vascular resistance. So If we know that, then the question is, do cardiovascular changes pre or post fetal growth restriction and preeclampsia? What I mean is it preeclampsia and fetal growth restriction that leads to severe cardiovascular sequelae for the women, or is it that something predisposed them to these cardiovascular changes? And then we move to Lin Fu, who is bottom left here. Lin did an enormous study at Imperial starting in 2016, where she recruited, taking over from Amita's work, over 500 women who were perfectly healthy before pregnancy. So we did comprehensive cardiovascular testing, metabonomics, everything. And we looked at particularly their cardiac output and vascular resistance. These were women who all had normal blood pressure, all had normal BMIs. They were perfectly healthy women. And we followed them through the pregnancy, and we followed them postnatally as well. And what did we find? Well, we found that in these women, those that got preeclampsia had a 16% lower cardiac output before they even got pregnant, and an 18% higher vascular resistance than those that had healthy outcomes. So really interestingly, even before pregnancy, cardiovascular disposition means that you're at higher risk of growth restriction and preeclampsia. But in your clinic, you wouldn't know this because you check a blood pressure. I check a blood pressure. You have to look at cardiac output and arterial function to understand this. And no one does that really outside research settings. I think my point is we probably should. So let's just move on to physiological responses to hypoxia. Well, we know this compensation of the baby, so the baby slows down in growing, it conserves energy. The Dopplers become a bit abnormal, the abdominal circumference falls below the 10th percentile. Then the baby becomes severely growth restricted. The baby ends up diverting blood away from its periphery and splanchnic areas to the adrenals, coronaries, and cerebral circulation. And eventually, the CTG becomes abnormal. And then the baby decompensates, and we get abnormal Doppler findings with umbilical and ductus venosus changes and middle cerebral changes. So that's what happens physiologically in a baby. So now we're looking at the other side of the placenta. We're looking at the side of the placenta that is the fetal side. And if we look at that fetal side in a hypoxic baby that is not getting as much nourishment and what it needs, progressively before the baby delivers, and this is a study from 2001 showing Doppler changes prior to delivery, we can see the baby's ductus venosus goes up. Prior to delivery, the umbilical artery does, the middle cerebral artery, PI, goes down. So we know all these things. These are the classic Doppler changes of a hypoxic baby. And if we just look at this, this schematic, I wonder if this schematic is going to work. Yes, it is. So let me just tell you what I think happens, that the maternal blood flow is affected, it goes up, possibly in response to a poor placenta. And as the uteroplacental circulation becomes more impaired, the umbilical artery Doppler increases in resistance and the middle cerebral artery resistance goes down. And interestingly, when we looked at this in our growth restricted babies, and this was a study done jointly with Wilfried Giesler's in Belgium and Herbert Valency's in Italy, in Rome, we found that the women who had the highest cardiac output had the babies with the lowest uterine artery PI. So isn't that interesting that the uterine artery PI was strongly associated with cardiac output? So a very high cardiac output equals low pulsatility index, whereas the low cardiac output gives you a high pulsatility index. And we, of course, know high uterine artery pulsatility index is most strongly associated with preeclampsia and growth restriction, particularly early onset. and exactly the opposite for vascular resistance. So the higher the vascular resistance, the higher the uterine artery PI. So that may not be surprising to you. But what we did think was surprising was that actually exactly the same relationship existed for umbilical artery Doppler. That the lower the cardiac output Z score, the higher the umbilical pulsatility index, umbilical artery pulsatility index was. And for vascular resistance, this is maternal vascular resistance, the fetal umbilical artery pulsatility index was higher. So the maternal circulation is actually conditioning the fetal circulation. And I'm not showing it here, but we've just published on this recently, a few months ago, that the middle cerebral circulation also is strongly related to the maternal circulation. So a low maternal cardiac output is strongly associated in a growth-restricted baby with a low middle cerebral artery PI. So now you can see the maternal cardiovascular function and the fetal cardiovascular function are actually extremely closely related. This little schematic, I made these schematics mainly for lay people, medical students that don't quite understand all these complex concepts. But I think it's pretty obvious to many of us that poor umbilical artery flow, high resistance, absent umbilical endocytic flow leads to a state of, or is associated with a state of hypoxia. And that leads to cerebral redistribution. And the point I'm trying to make with this schematic is that that is strongly related to poor uteroplacental circulation. And the poor uteroplacental circulation is strongly related to the maternal arterial function and cardiovascular function. So let's move on from that in the last few minutes of my talk. So do formerly preeclamptic women have abnormal vascular function after pregnancy? And if so, can it be improved? So if a woman has preeclampsia, that may of course be, as I've shown you, due to a pre-existing cardiovascular disposition. But it could be that the preeclampsia makes it worse as well. Now, I'm sorry, these bar charts are a little bit small, but I just want to show you, these are healthy controls on the left, and these are formerly preeclamptic women on the right. And you can see that formerly preeclamptic women have higher intimal medial thickness in the carotid artery. They've got lower flow-mediated dilatation. I think Mara will remember we did a lot of work on arterial function when we were together. And you can see that formerly preeclamptic women, after their pregnancies are over, have quite disordered cardiovascular function. But the good news is that, and this was an exercise training program, that actually intimal medial thickness and flow-mediated dilatation both got very significantly better with exercise. So it's not necessarily a bad story. It's not a story that ends badly, because if you can identify women with these cardiovascular risks and exercise them and give and reduce weight if it needs to be reduced, then the cardiovascular systems can be reset to an extent. And this is from Mark Spanderman, some very nice work, that again, in formerly preeclamptic women, you can improve plasma volume. This is controls having exercise. So of course, you can increase plasma volume in controls, but in formerly preeclamptic women, you can increase it to an even greater extent. Now, the formerly preeclamptic women will never reach the same level as the controls that exercise. But if you look, they'll reach roughly the same starting level as controls. So you can certainly put them back to a very good level of cardiovascular function. Why am I talking about plasma volume here? Well, plasma volume is quite a sensitive index of endothelial function, arterial function. And women with severe preeclampsia and growth restriction have very low intravascular fluid. So I think we've answered the questions that these women do have abnormal vascular function after pregnancy, excuse me, and that it can be improved. So what other interventions can we use? Can we use interventions when women actually have preeclampsia? Can we use interventions to reduce the risk of preeclampsia and growth restriction happening? And can we optimize before pregnancy? So I'll take these in reverse order. Let's look at the endothelium here of a blood vessel. The endothelium produces nitric oxide. Nitric oxide diffuses to the arterial smooth muscle, leading to vasodilatation. But we can, of course, give nitric oxide as nitric oxide donors, and this includes GTN, glycerol trinitrate, isosorbide mononitrate, and glutathione, GSNO, S-nitrosoglutathione. So one of the earliest studies of this was one I did with Herbert Valencis back in 1997. And we took women at very high risk of preeclampsia and growth restriction. So they had bilateral notches, and we gave them GTN patches to restore endothelial function, or we gave them placebo. And the outcomes were preeclampsia, birth weight, mean gestation at delivery. And we found that in the placebo group, there was a significantly lower risk of adverse outcome. So it showed that potentially it was only a small study. It was 40 patients, but it did show that there was a signal suggesting some therapeutic efficacy from a nitric oxide donor given prophylactically to women at high risk based on uterine artery Doppler, rather than necessarily based on pre-existing disease. So it was true prophylaxis. Herbert has done further work on this, and he has shown that in women with fetal growth restriction, it is possible to improve umbilical artery Doppler, and it's possible probably to improve their growth by giving GTN to dilate the blood vessels and giving fluid expansion to increase uteroplacental flow as well. And you can see here that end-diastolic flow has reappeared in one of the women in whom he's treated. And the total vascular resistance at the bottom here in the women he's treated has gone down from 1642 to 1221 there. So certainly reduction in vascular resistance, increase in plasma volume, and improvement in maternal and fetal Dopplers. So with Tom Everett, with whom I worked approximately a decade ago, we used a new nitric oxide donor, GSNO, S-nitrosoglutathione, and we found a very similar sort of thing in women with growth-restricted babies, that giving GSNO, which relaxes blood vessels, probably improves cardiac output. We saw that umbilical end-diastolic flow returned, and we published on that in the British Journal of Clinical Pharmacology in 2014. So is all this relevant? Does it matter in terms of your practice? Well, you are all obstetricians. You'll see women with preeclampsia. You might see them at 24 weeks with severe preeclampsia growth restriction. You might see them at 40 weeks who, shaking like this. You need to give them magnesium or else they get a fit. Well, is what I've said to you relevant at all? Well, I would say to you it is, because blood pressure describes the end result of changes in cardiovascular function, so cardiac output, intravascular volume, and peripheral resistance. If we define a condition like preeclampsia on blood pressure alone, it's incredibly crude, and we miss the underlying cause. We don't see what's happening with the arteries and the heart and the vascular function in general. So I think that the problem is that because we've ascribed hypertensive, we've looked at blood pressure, which is the wrong measure. We should be looking at cardiac output and vascular resistance, to the placenta, the poor placenta we've blamed for all of this, when the placenta actually is just trying to behave normally as a conduit between the mother and the fetus. And this mindset, placenta, has stopped any sensible research, really, for several decades into preeclampsia. And what I want to just explain to you is hypertension in pregnancy may be associated with a high or a low cardiac output and high or low vascular resistance. And if you know the underlying problem, then you can treat it rationally rather than just using whatever antihypertensive you'd normally use. So let's talk about a woman who I saw. I published this in 2017, so it was just before I published this, a Somalian woman with no medical problems. She was 38 weeks. She presented with a very high blood pressure, 170/105, urine protein creatinine ratio 485. Baby was small, 5th centile, with abnormal umbilical artery Doppler. And gave her nifedipine, blood pressure came down a bit. So then the question is, her blood pressure is still dangerously high. What intravenous agent are we going to give to control her blood pressure? So let's just think about this. It's a small baby, very high blood pressure, abnormal Dopplers. So this baby isn't getting enough circulation, uteroplacental circulation. So actually in this woman, the vascular resistance was very high. Cardiac output was actually very low. So if we give labetalol or a beta blocker, we're actually going to reduce the heart function even more. We'll reduce cardiac output, and that's not a good thing. But actually, we know from, do you remember Herbert Valenci's slide, where we looked on the left-hand side, we saw those babies with early onset growth restriction and fetal growth restriction and early onset preeclampsia, and they had very, very high vascular resistance. So what we need to do is reduce the vascular resistance. And indeed, this woman responded very well to hydrolysis. Now, I'm just going to move on to some further thoughts, because if we really do want to understand what is going on in women and their blood pressure, why do we see them? In England, we see them at 12 to 14 weeks. We might then see them again at 20 weeks, possibly 28, 34, 36, 37. Now look, you're missing out an enormous amount of someone's blood pressure in that time. Blood pressure is changing all the time. If we see them 8 times in a pregnancy, that's ridiculous. We're missing everything in between. But it's possible with wearable devices, and we did this work and we just submitted this for publication. We get the most beautiful curves of individual patients with their blood pressure readings, with their heart rate readings, with everything and their weight. So if we are going to be serious about starting to understand physiology in pregnancy, we can't do it based on the occasional measurement at 4 or 6 weekly intervals. Now, I think in Chile you have a much more sensible approach to seeing women more frequently, but in the UK we don't. And these are home body weight recordings, and you can see exactly the same thing, that we can record their cardiovascular function and their weight with a high degree of fidelity. Now, I'm just going to say one more thing before I finish. I think I'm just about in time for the questions. I've been very interested in looking at interventions, because we know women prior to pregnancy who are more likely to get preeclampsia and growth restriction have low cardiac output and high vascular resistance. Ed Mullins, who's was my lecturer and is now a senior lecturer, and I have been working on giving women beetroot juice and exercising them. And we've done a randomized control pilot study where we say to women, either you have standard advice or you exercise, and we give them the wherewithal to exercise, or we give you beetroot juice, which is a naturally occurring nitric oxide donor, or beetroot juice and exercise. So we've just finished this study, and it does suggest, I won't give the game away, but it does suggest that you can intervene and actually reduce blood pressure and improve cardiac output with a relatively short period of cardiovascular optimization. And we want to do this in women who are obese, women who have cardiovascular conditions, women who are diabetic, women who are hypertensive, because it's in these women that will potentially show the biggest chance of success and the biggest reductions in cardiovascular problems. So anyway, I love quoting from Galileo and the whole idea of the placenta and the cardiovascular system, which revolves around, which is the Earth revolving around the sun or the sun revolving around the Earth. But actually, I don't think we need to make that judgment. I think that it is the combination of cardiovascular dysfunction and a placenta that is then secondarily damaged that causes many of the problems we see. And I'm quite certain that it's that poorly perfused placenta that then pumps out biomarkers and vasoactive substances that lead to hypertension. So I'm just going to say thank you very much to my collaborators and our funders over the last few years for this work. And I'm going to, Maura asked me to speak for 50 minutes. I've spoken for 45, so I hope I'm in time for a few questions.
Excellent, Christoph. Thanks a lot for your nice talk. Really very exciting and challenging talk, because it's something that you have, I have heard in different congresses and webinars now, recently. And it's something that is difficult to understand, because as you said, we are being sort of researching based on the concept of a placenta. No, placenta is sort of the way that we always think about of preeclampsia, about of a fetal growth restriction as a genesis. No, so it's difficult to try to think that the origin of this condition are the hemodynamic or maternal hemodynamic changes. No, so
yes.
for that I think is very challenging. No, because you need to sort of switch your brain. No, make some sort of switch in your brain to try to understand this new concept. No. But for that, I think it's very interesting, because it's something new with old concept. No, it's new, but with using old concept. No, it's not something really new. No, it's something that you try to connect different ideas. No, based on these hemodynamic changes. So I think for that is really challenging, and it's very nice. I will sort of leave the just to see everyone here. That's it. So it's congratulations, first of all, because it's a really nice talk. You start with the basic ideas about placenta and then move to the hemodynamic thing, which is, as I said, is something really interesting. And the graph that I like a lot was this correlation that you find out about between the umbilical artery, PI, and the cardiac output, I think was, yes. No? Cardiac output and the vascular resistance, which was very, I don't know, fantastic, not to see this correlation, which is something that I think I have some sort of clue sometimes, because you see these sort of changes when the mother have a very high blood pressure. And what my question would be, how would be the way that the maternal blood pressure is transmitted to the baby? You have some sort of idea about that? How you can think about this?
Yeah,
is it molecular things, or is sort of another kind of sort of biomarker that is sort of moving from the mother to the fetus?
Yeah, I think it's that's a very interesting question. I think it's largely to do with oxygenation. So I think that there is a signal somewhere that leads to hypertension and vascular dysfunction if a baby is hypoxic. So I think that's where the placenta is probably pumping out whatever it is. I mean, we all talk about SFLT and PLGF. There are any number of other biomarkers that potentially could do this. And if the blood pressure is very high, it's indicating to us that the placental interface with the fetus is just not functioning well. The transfer is very poor for whatever reason. And then you have a baby that's hypoxic. And then because the baby is hypoxic, you get umbilical artery raised umbilical artery PI. And in the brain, I mean, the brain blood vessels sense oxygen, and so they vasodilate. People often get this wrong and say the brain vessels are innervated. They're not innervated. They sense oxygen directly. So if a baby is hypoxic, the resistance goes down. And that is, of course, what we all understand by brain sparing, and that's been known for at least 20, 25 years or so. But the really fascinating thing here is that you can draw a direct line between the maternal circulation and the baby's brain circulation. And, they are not connected, but there is something happening in the maternal circulation that leads to hypoxia, that then leads to the baby's cerebral redistribution. I can't pretend that I understand it exactly. I just know that we see the signals, and we see that is very clearly the case.
Yeah, And I think that is sort of fascinating, because always you think that placenta or all the fetal hemodynamic is sort of independent to the maternal hemodynamic. And you show that it's not like this, at least in your graph.
Well, yes, when we first submitted that paper for publication in a very well-known journal, we said the fetal and maternal circulations are connected, and the reviewer said, "What rubbish! Of course they're not connected." So they hadn't read what we'd written properly, but but it is possible still to challenge what people think, and people think you're mad. So I don't think I am mad. It's true, but I can't quite understand it. I can't quite explain it.
Yeah, that's true. Edgar,
were you saying it's true? Edgar? It's true that I'm mad, or it's true that the
no, it's true, and you're not mad at all. I think Edgar, what do you think about
Edgar was going to ask me a really difficult question. It would be very upsetting if I didn't get a difficult question from Edgar.
No, Christoph, I just want to congratulate you for this presentation. I mean, it is really complicated to put everything together. And it sounds so easy to follow when we are listening to your presentation, but in reality, it's not so easy. I just have 2 comments. The first comment is, how do you measure cardiac output? How reliable it is? How do you measure vascular resistance?
Yeah, okay, so that is a very good question. So for any of you that love cardiovascular measurements, I think that if you started looking into it, you'd find that there are any number of ways of measuring cardiac output. So, for instance, and this is where in London, in the southwest London at St George's, they use echo. Okay, in northwest London, I'm very, very indecisive. So we use not echo, but we use gas rebreathing techniques. We use Doppler waveform analysis that allows us to indirectly work out cardiac output. And we also use impedance, bioimpedance, bioreactance devices. And once you have a cardiac output and a blood pressure, you can work out the vascular resistance, so you can derive one from the other. But the problem is that these different techniques do give you quite different results, as Edgar, I think, is inferring. And you've got to be very, very careful, because if you start measuring cardiac output on a woman with, for instance, an inner core device, inert gas rebreathing, you have to use that device throughout to get reproducible results. You can't switch to an OSCOM or can't switch to NICOM or whatever it is. Now, for that work that I showed you, that showed the relationship between cardiac output and vascular resistance and umbilical artery Doppler and middle cerebral artery Doppler, we actually used 3 different devices. So Wilfred used a bioimpedance device, Herbert used OSCOM, and we used inner core. So we actually used different devices, and we normalized them for gestational age. So for each device, we had a different range based on the device. And then we could compare everything. So I'm going into statistics, which may be a bit too much at this time of the evening, but we could then use Z-scores for each individual woman, irrespective of what technique we had used. And even doing that, we found that there are clear and significant relationships. But the truth is, Edgar, had we used all the same technique, we would almost certainly see much stronger relationships. So the truth is that there are so many techniques out there, and they don't necessarily agree with each other very much. But you can normalize them, and that then allows you to collaborate with other centers that may be using different devices.
Christoph, and my last question of time, is there any prospective study for prediction of preeclampsia using this method, evaluating cardiac output and vascular resistance?
There are plenty of studies that use mean arterial pressure, that use augmentation index, and have added vascular resistance into the first trimester assessment of preeclampsia growth restriction, but they're not very good. So I don't think we're at the stage yet where we can use cardiovascular indices to predict. I think they're it's much more understanding the physiology of what's happening rather than predicting. Now, I've said that, but together with colleagues in the metabolomics department of Imperial, we have put together cardiovascular indices with metabolomic indices well before disease happens. And we can see that if you combine metabolomics with cardiovascular function, then we get a much better predictive ability, but it still isn't good enough. It still isn't good enough for clinical use.
Thank you, Christoph. Thank you.
Thanks, Edgar, for your questions. Alvaro, you asked me to ask a question as well?
Yeah, of course. Well, first, I would like to thank Professor Lees for this brilliant presentation. It's always a pleasure to hear your talks. So thank you very much. One question is regarding fetal growth restriction, because you already demonstrated that in FGR, you have a very low cardiac output with a high vascular resistance. And also this is increased even more when it's combined with preeclampsia. So, but in that case, when you have preeclampsia with growth restriction, you use a vasodilator to treat the severe preeclampsia, for example. But what happens if you have FGR without preeclampsia? You know that the vascular resistance is high, but the blood pressure is normal. Can you use, for example, a vasodilator to improve the cardiac output in this pregnancy, even the blood pressure is normal?
Yeah, so that's an extremely good question. And on one slide, I just touched on that. And if you go back to Herbert Valenzies's work, and I can send you some of the key papers there, he has done exactly that. So he's taken normotensive IUGR, and he's shown that these women have very high vascular resistance, but they still have normal blood pressure, probably because they've got low cardiac output. And he has vasodilated them with nitric oxide donors and increased their oral fluid intake. So he's filled up their blood vessels and vasodilated them at the same time, and shown that you can improve uteroplacental function. And his findings are quite clear. I mean, I'm sure he's right on that. I think that you just have to be a bit careful doing that, because if you don't increase intravascular volume at the same time as you vasodilate, you know, that could cause problems, because you could end up with quite a low blood pressure. But you know, if you do it carefully, it's well, Herbert. If you look at Herbert Valenzies's papers, he will explain how he does it. And I actually think that if we, you know, this could be something we could do as a multi-center trial, because with good monitoring techniques, when he did this work was about 10 years ago, and the monitoring techniques weren't as good as they are now. With good monitoring techniques, actually, I think you could manage severe growth restriction with fluid replacement and with vasodilatation. But I would warn anyone just to be really careful about this, because if a woman has an underlying pre-eclamptic tendency and you give her lots and lots of fluids, then you could end up with someone going into pulmonary edema.
Okay. And also, because you demonstrate this correlation between the uterine Doppler and the vascular resistance and the cardiac output. So for me, I think you think the same. The uterine Doppler didn't remodel. The vessel that remodeled is the spiral artery. So the uterine artery continue with the muscular layer. So if the uterine Doppler is with a very high PI, it is reflecting that is a vasoconstriction, like another vessel in the body of this patient. So maybe you can estimate it, that if when the patient is with preeclampsia and you assess the uterine Doppler and it's increased above 95, 99%, you can estimate that this patient has a vasoconstricted phenotype.
Yeah.
And so maybe you can use it as a practical approach if you don't have the way to measure the cardiac output and the vascular resistance.
Yeah, that is also almost certainly true. And the interesting thing is, of course, uterine artery Doppler is particularly good for early onset growth restriction preeclampsia. And that is the phenotype that is associated with high vascular resistance. And I didn't show the slide because I didn't have time, but if you look at our work and Herbert's work and uterine artery Doppler, the late onset preeclampsia, the uterine artery Doppler actually is no different to controls. And the late onset, of course, is associated with, or the type that is not associated with growth restriction is associated with normal vascular resistance. So I think your point there is probably correct, and that will be a very interesting thing to look at if uterine artery Doppler actually was quite a good surrogate marker for the intravascular depleted, high vascular resistance, low cardiac output phenotype.
Yeah.
I don't think anyone's done that actually.
Yeah, that will be good to research out, bro.
I'm applying for a grant for that.
Yeah,
I want to do that because I think that could be reflected.
I think it could. I think it could.
Yeah. Pablo who? Because it says Francisco Guerra, but it's not, no? It's Pablo. Pablo, please, you're mute. Excellent. Now you can ask the question.
Yes, hello, Mauro. Hello, Professor Lees. Thank you for your excellent talk. We use in our hospital and daily clinical practice in pregnant women the resistance index. We obtain that dividing the mean arterial pressure over the maternal heart rate. And if we have a high resistance index around 1.8, we assume that this pregnant woman or puerperal woman and after the delivery has a high resistance state. And in contrary, if it has a low resistance index, a high cardiovascular output type of preeclampsia. And in clinical practice, for us, it works well. For example, if we have a pregnant woman with a mean arterial pressure around 120 and a heart rate around 60, we have a resistance index around 1.8, and we give nifedipine after giving labetalol. That labetalol didn't work, and using nifedipine, it works very well. What do you think about that?
Okay, I have to say I've never heard of that index at all. So blood pressure over heart rate.
So mean arterial blood pressure over heart rate.
Mean arterial over heart rate. So I'm just thinking about the physiology of this. So the women who tend to have growth restricted babies tend to have slower heart rates, and they have high blood pressures, obviously. So, I suppose it would work there that you would have. So presumably, if someone had this high index, you'd give them a vasodilator. You'd give them a vasodilator, would you?
Yes, and it works well. Yes.
Yeah, that would work. And a woman who's very full was probably have a low. So you should have a low index, and you'd give her labetalol, beta blocker.
Yes.
Okay, that would work because of course should be tachycardic, and you'd be trying to reduce the chronotropy of the heart. That's a really interesting index. I've never heard of that index, but I'm going to go and look that up. I'd be very interested to see where that's come from.
So to be honest, I heard that in a talk by Professor Spader from Netherlands.
Okay. Professor, was it Spanderman, you mean?
Yes, sorry, Spaderman, yes.
Spanderman, funnily enough, I was on a webinar this evening with Professor Spanderman because we've got a hemodynamics congress in late June. You must all come to Europe for our hemodynamics congress in Holland in late June, and Professor Spanderman is the organizer of that. So
Yes.
I will ask him, I will email him tomorrow and say, tell me about this index, because he's
Yes.
never told me about it. So
Yes,
thank you very much.
It's very
Excellent.
useful, I think.
It's an interesting concept. I can see that it could work. It's not as good as doing the cardiac output, of course, but it's
Of course. Yes, but in clinical practice, I think it works very, very well.
well, it might. I can see why it could actually.
Thank you.
Thanks.
But at the end of the day, the same sort of a concept, no? Because you're trying to treat the patient, the preeclamptic patient, because of the cardiac output or the vascular resistance. At the end, it's the same concept, but using different index or devices, no? As you said. And I think it's very, because you said in your talk that blood pressure is just, or the measurement of blood pressure is just one sign, no? The thing that you need to do is to try to expand that, no, to cardiac output, or to know about cardiac output or to vascular resistance, which would be very interesting, no, to try to introduce that in the definition of preeclampsia and at the same time in the assessment of those women, no. That would be very interesting.
It would be interesting, Mauro, if we banned the measurement of blood pressure, because then you'd have to look at cardiac output and heart rate and vascular resistance.
Yeah, but if you do that, you sort of produce sort of this new index that you heard is going to be sort of say goodbye to this index. The new index, no, the one
possibly, yes, we'd lose that index for sure.
No, but interesting, no. Excellent. I think it's 9:10 here, but for you it's after midnight, no?
It is after midnight. Yes,
after midnight.
I'm remarkably awake because I was on call last night and I didn't sleep much.
So I think
I've made some sense.
I don't know if there is another question or any comment about the talk or about the Alvaro. You want to say?
In the YouTube chat, there's no question.
No question.
Just one question. Do you think that maybe for prediction is better when you use hemodynamics to perform longitudinal assessment? Because I think that in one instance maybe it's not good, but if you see that in the between the first and second trimester, for example, you don't reduce your your vascular resistance and all that, maybe you tend to develop some of these diseases, and maybe it benefits from a closer approach. Maybe.
Yeah. Well, I think the first part of your question is right, that if you looked at the delta, the change in cardiac output and change in vascular resistance, but the second part you said in the second trimester, the issue is the main changes happen between about 6 and 12 weeks, 6 and 14 weeks. So I think it might be possible to make those predictions, and we've looked at them, and they are actually strongest in the first trimester. So they're strongest between either pre-pregnancy and 10 weeks or 6 weeks and 10 weeks. Once you've got to 16, 18, 20, 22 weeks, you're too late because the changes level off.
Okay. So with the fertility clinics, maybe you need to do the research. Yeah,
we need to do, we need to do clinics from the moment the HCG test is positive.
Yeah, with fertility, IVF or something like that.
Yes, that's right.
Yeah.
That's something that is not related with the hemodynamic changes, but maybe it's sort of related, but it's just about your new TOEFL, the TOEFL 2.
Yeah.
Because we are sort of revise or sort of read some papers about that. And always I'm sort of curious, no? And maybe you have some sort of answer to this curiosity that I have about the new index, no? This index, because you know that everyone in the world is sort of using the middle cerebral artery, which is the cerebral placenta ratio. But in your TOEFL 2, you are using the umbilical cerebral ratio or something like this. How do you call it? Because it's on the other way around, no?
Okay.
I remember that you said something about that, which is better than the CPR. What is the sort of the meaning of this? What is why you use that and not the normal one, or not the normal one, but the one that we use in the rest of the world?
Okay, so so if you like your history, I'll give you a history lesson. The UCR was described before the CPR. Okay, so you need to talk to Kurt Hecher about this. Professor Hecher from Hamburg is a lovely fellow. The only way you can get him angry is to say everyone uses a CPR and that was the first index ever measured or ever described, because he will say, I described the first cerebral index, and it was the umbilical cerebral ratio in 1993 or 1992 or something. So the UCR was the first.
Christoph, sorry to interrupt, but the cerebral placental ratio was described in France in the 80s. And it was done using the anterior cerebral artery, not the
the anterior cerebral, but not the middle cerebral, Edgar.
Yeah, because they didn't have the same devices that we have now. At that time, they have an external Doppler. So that's why they use it in the anterior.
Yeah,
so,
I agree with you, but no,
I think that we discussed this when we wrote the guidelines of Doppler. So, but yeah, it was a bit before the 90s.
Yes, I'm sorry. Yes, I remember we had this discussion when we wrote the Doppler guidelines. So it's getting too late. So, but anyway, when the discussions with the Doppler, I think Edgar will agree, when the Doppler machines, the color Doppler machines came into regular usage in the late 80s and early 90s, the UCR was, I think, it was definitely described by Kurt, and just a month or two later came the big paper on cerebroplacental ratio. So anyway, the truth is there is a rivalry between the two. Now, of course, the CPR is much more frequently used. That has just caught the imagination. We've done quite a lot of modeling with the UCR and the CPR, and the truth is there's not much difference, but in the abnormal range, the UCR does discriminate better than the CPR, and it's the abnormal range that's important. Now, if you think about a protein creatinine ratio, if you've got worse preeclampsia, which way does the ratio go? Tell me. Anyone? It goes higher. PCR goes higher. The S-split PLGF ratio in severe preeclampsia, does that go higher? VQ ratio in a pulmonary embolus, it gets higher the worse. Every ratio in medicine is designed to become higher the worse the condition. Yeah. Okay, so, and that is what the UCR does. The CPR becomes compressed in the abnormal range.
That's true. Yeah.
So now I do realize this causes an awful lot of this can cause an awful lot of argument, and I've been on webinars and calls where people start shaking their fists and getting really up. I didn't know that the CPR could cause such raw emotion and anger, and all I'll say is that the CPR, there really isn't that much difference. But if you are a mathematical purist, and if you look at other ratios in medicine, you would see that the UCR makes a bit more sense than the CPR.
Makes sense. Yeah, that's true. That's good point. Good point, because it's always a sort of debate here about why, not debate, but we sort of talk about that. We always think that it's something that the British people like to sort of drive on the right and we ride on the left and things like this. But it's more than that. That's interesting.
We scan with the left hand. Do you remember?
Yes.
Yes, scan with the left hand.
Do you scan with the left hand? No,
in the King's College. No. In Chile we scan with the right hand, but in the King's College using the left hand. No, but but what just was at the King's. It's not it's not in England like this.
Yeah. No, I still scan with this hand.
Yeah, with the right hand. Okay, left. Perfect. I think it's
Yesid, no sé. Yesid, do you have any question? Are you here?
Yes. Thank you, Dr. Lee, for this great talk. And I just wanted to ask you whether, there is some data showing that when the gestation is advanced, there is more rate of late onset preeclampsia. And this also true about when you eliminate the placenta from the gain, everything comes to the normal. So I am going back to the origin and asking you whether you envision, if we embrace the management of the hemodynamic of the woman, do you envision that maybe we can prolong more the pregnancy when we use antihypertensive and more accurate than what we are using now? So how do you see the future of the hemodynamic at this point? You're going to help us at that point?
Yeah, I think so. I think that, and we're already doing this in research studies, and the neonatologists, interestingly, are doing this as well with special equipment to measure cardiac output and vascular resistance in neonates. But yes, I think that if the difficulty has been that these very nice ideas from Easterling and others, and from the Dutch groups in the 1990s of giving fluid replacement to women with preeclampsia and HELLP syndrome, because there are lots and lots of papers on this, but they didn't have good monitoring devices. They didn't have what we have now. And I think if we were able to do that now to women with severe preeclampsia, to women with severe growth restriction, I think that would make a difference. But it's difficult to do because everyone thinks you're mad if you do it. They think it's dangerous if you give these women fluids. And I'm continually, okay, in my hospital, we have a preeclampsia protocol. If someone has preeclampsia, they get limited to 86 milliliters of water fluid every hour. In fact, they're often limited to half that. And funnily enough, their renal function becomes very abnormal. Their creatinine goes high. And they end up with kidney injury after a few days, after 2 days. And I think that now I'm not saying that could necessarily be avoided, but if we gave them a little bit of more fluid and watched the cardiovascular function carefully, then I think we could do that safely and probably prolong a pregnancy.
And thank you for your answer, because I was going directly to that point, and we are using the cheetah, we're using bioreactants. And they're giving us also very nice new parameters like the thoracic fluid content that is also helping us to predict which women are going to develop the pulmonary edema if they are having problems with the cardiac output. So I agree with you, and we are using a lot this algorithm by Stolt saying which woman is going to respond or not to labetalol. So thank you for that, because this is how we envision that maybe maternal hemodynamics is going to help us. It's going to help us to manage and to prolong the management of the pregnant woman with preeclampsia.
Yeah, in 10 years' time, everyone will be doing this, I think. It's just that we've got to get it in there.
Okay, excellent. I think it's fine because Christoph needs to sleep, and we need to go to our home to try to sleep later on. But anyway, it's good. This meeting was fantastic. This webinar, I'm very, very grateful, and very thanks, Christoph, for being here, for leave this time for us. So thanks a lot, and I hope so. I hope so that I will see you next year in Europe in some of the congresses at ESOC or the King or the Fetal Medicine Congress. I think Fetal Medicine is going to be, I think, in June. I have seen some messages that it's going to be in Crete. I don't know where it's going to be the ESOC. Where is going to be the ESOC next year?
London is ESOC next year.
So everyone is going to go to your home. Maybe it's a barbecue sort of like this, no?
Yeah, we wanted to do it in Europe, but in the end, it was it ended up being
COVID is going to be the issue. But anyway, I hope so. I hope so that we will meet again in Europe, in any place. And thanks a lot. Thanks a lot for being here, for giving us this fantastic talk and these challenging ideas that maybe we can sort of change it in a research and try to do more or create more ideas in the future. So thanks a lot, Christoph. Thanks a lot for everyone that is here. Edgar, thanks for coming again. Jacid and Marcelo is here, everyone. Thanks, and see you next year in March, where we will start again the new webinars.
Feliz Navidad.
Feliz Navidad. Próspero año
Thank
nuevo.
you, Christoph. Take care. See you soon.
Bye.
Bye, everyone.
Bye. Thanks.